Okay, just before I start, I want to ask how many people in here actually put in slings? And how many people do single incision slings? Okay, so some, but not a lot. So the mid-urethral sling was approved in 1998, as we know, and since that time, over 3 million slings have been placed. We know they're highly efficacious. Traditionally, there's been two routes, the retropubic route and the transobturator route. And there's tissue fixation of the mesh arms to nearby tissue. And studies have shown that the average length of mesh for the retropubic sling is about 20 centimeters, and for the transobturator sling, it's been 17 centimeters. So why would we consider a single incision sling? So mid-urethral sling requires blind passage of trocars. And in the retropubic slings, there's been reports of bladder injury, bowel injury, vascular injury, and voiding dysfunction. And in transobturator slings, there's been reports of groin pain, hip pain, especially in physically active women, and injury to the neurovascular bundle. So I'm sure if you've done enough slings, you've seen the picture on the left, which is a trocar injury to the bladder. I do work in that.
That wasn't my patient.
Okay. Okay. I was going to give you credit for it. So on the left side, I work in an academic institution. I train residents and fellows, and I hate to admit it, but we see that more than we'd like. Maybe I'm not that good at it, but we do see it. And then on the right side, this picture came from Dr. Flynn, but he didn't do the surgery. And just looking at this, I don't know the exact case, but this looks like to me probably the trocar was put through the bladder and it was missed and the sling was deployed. And yeah, and you know what? As experts in the field, we say this can never happen to me, but I found one case of mine where I did do cystoscopy and I found it just like that, so it can happen. And I think this is a nice picture showing what he took out. You do see the tissue fixation on these long arms. So the single incision sling, it's put in through about a 1.5 to 2 centimeter incision in the vagina, and the mesh is similar to the ones used in the traditional retropubic and transobturator slings. It does utilize a shorter piece of mesh, and the currently available slings are 8 to 9 centimeters, so about half the length of the traditional full-length slings. It avoids a retropubic trajectory, and it avoids adductor muscle perforation. And on these slings, there's tissue anchors that are usually deployed into the obturator internus or membrane. And right now, to my knowledge, there's 3 commercially available slings. I'm not supposed to disclose the manufacturer names, but I put the pictures of them here. 2 of them, the Solex and the Sarah 1, they're slings that have 2 anchors on tissue anchors on both sides. And you deploy them by putting in the trocar on one side, deploying it, and then on the other side you attach a trocar, you put it in to the right space, and you don't deploy it until the tension is right. So you can push it in a little bit or take it out before you deploy the sling. And the Alta sling is a little bit different. It has a tissue anchor on one side, and on the other side there's a tensioning suture. So you deploy both sides, and then you can pull that tensioning suture until you've reached the appropriate amount of tension, and then you simply cut that suture. I personally used a lot of 2 of these. The third one I've not used because it wasn't available in my hospital, but I believe it probably functions just as well. I don't want to get into each company's, why theirs is better or the mesh products. I think they all work well. So in this picture, we kind of see the traditional routes of sling passage. Picture A is a synthetic retropubic sling. We perhaps put a little looser. The transobturator may be a little bit tighter. The thing with the single incision slings, Picture C, it shows a kind of transobturator-like approach and retropubic-like approach. Right now, the ones that are available use the transobturator-like approach. It is a little tighter. We kind of put a little more snug to the urethra. And I think that's because the tissue anchors, they don't have these long arms that get fixated to the tissue, so perhaps we need a little more tension on the slings. And when I talk to a lot of people who don't do single incision slings, the knock, I think, as Dr. Sutherland had mentioned, is previously there was no data on this, or there wasn't significant long-term data, and so people didn't feel comfortable putting them in. Well, in September of 2022, there was a Cochrane review, and there was a lot to it, but the key message are single incision slings are as likely as mid-urethral slings to cure incontinence and may be associated with less pain. However, this evidence was limited to 2 years. And then after that, in the New England Journal of Medicine, there was a single-incision mini slings for urinary incontinence in women study, and it was a randomized non-inferiority trial. And they randomized about 600 patients between a single-incision sling and a tension-free mid-urethral sling. And now these are patient-reported satisfactions, and as you can see, the patient-reported success rates, and it was a non-inferiority trial, and did show that the single-incision slings were non-inferior, and in fact, in this study, the patient-reported success rates were higher in the single-incision slings. And that data goes out to 3 years. I mean, I understand we don't have really long-term data, but things are suggesting that these slings work well. And secondary outcomes, there was no difference in lower urinary tract symptoms, quality of life, sexual function, mesh exposure. There were slightly higher rates of dyspareunia and coital incontinence. So I just want to tell you about my journey to single-incision slings. You know, I did fellowship in Seattle, Washington with Dr. Kathleen Kabashi, and back then we were putting in a ton of slings, both transobturator and retropubic slings, and back then we kind of stratified based on leak point pressures and other symptoms to decide which ones we did. And when I came out, I said, I'm going to do everything exactly the same way. Well, when I started practice in 2011, I put in a fair amount of transobturator slings, and I had noticed this issue with the groin pain in especially active younger females. I basically stopped doing the transobturator slings and just kind of did retropubic slings for a while. Then I started to look around, and I said, I'll try the single-incision sling. I started them in 2013. I did continue to do retropubic slings. However, I had such good success with these slings in my practice that currently my breakdown is probably something like 95% single-incision slings to about 5% retropubic slings. And so I've been very happy with the results. And, you know, here are some of my thoughts about these slings. There are less incisions, so you don't have the stab incisions in the suprapubic area or, you know, under the insertion point, the adductor longus tendon in the groin crease. And I think there's quicker recovery. I mean, I may be a little bit aggressive, but I usually tell the patients they can go back to full activity about 2 weeks, and I tell them to hold off on sex for about a month until the incision is healed. I think, you know, there's less pain involved with it. Interestingly enough, I once put one in a 40-year-old female, and I went to clinic the next day. I went to lunch at the deli where I always go, and I caught her working the next day, and she felt like she had nothing done. So, and she was very happy with the results, and she actually became one of my best referral sources to everyone who went to lunch there. And as you know, the trocar passage, you're not going through these blind spaces, and especially with me, residents and fellows, that makes a big deal. I do think it's a quicker procedure. And so far we've had excellent results, and I also think it's easier to remove. Now, I haven't done a lot of these removals of these, but when we do, it's a shorter piece of mesh. And you know, a lot of times when I had to remove the whole retropubic sling, I might have to take a robotic approach, you know, enter the bladder and things like that if it's gone into the bladder. You know, with these slings, traditionally we can get away with, yeah. So, and with the single-incision slings, you can usually remove it through a transvaginal incision. So I think it's a less morbid procedure. So I think everyone should give it some thought. Interestingly enough, I know we had some excellent lectures on Bulkamid and the other therapies. It's interesting. In your practice, everyone wants Bulkamid. In New York, people understand the risks, but they want the thing that gets them fixed the quickest with the less need for long-term other procedures. So it's interesting how different practice patterns work. Thank you very much.